So once again, a warm welcome from me to the Kiel Imaging Seminar. It is great to have you here with us today. It is my pleasure to introduce our guest speaker to you, Dr. Geir Ringstad. He's the head of the neuroradiology at Oslo University Hospital and associate professor and group leader at the Jebsen Center for Brain Fluid Research at the University of Oslo, Norway. His research concerns novel methods for imaging of the glymphatic system and lymphatic brain clearance. For this purpose, in vivo CSF tracer, intrathecal MRI contrast agent is used in conjunction with multi-phase MRI and applied in patients with CSF circulation disorders and dementia. Professor Ringstad will share his experience in intrathecal contrast enhanced MRI, or for short gMRI, for assessing cerebrospinal fluid CSF tracer exchange with the brain tracer movement along the brain's outer boundaries and tracer clearance of the CSF. He will also address the influence of sleep on tracer clearance from the human brain and the possible role of impaired sleep in the pathogenesis of Alzheimer's disease. Now, to the audience, before we start, please wait with your questions until the discussion. And with that being said, Professor Ringstad, the stage is all yours.
Thank you so much, Dr. Fayed, for this kind introduction. And thank you so much for the invitation to present here at the Kiel Imaging Seminar. I have just a couple of disclosures. They are here. And here are some outline of this talk. I will first talk about a metabolic role of cerebrospinal fluid in brain clearance and neurological disease. I will then present some principles about intrathecal or CSF tracer-based enhanced MRI, what we call gMRI or glymphatic MRI. Then we will look at the CSF tracer propagation at the brain surface, its exchange with the brain, and its clearance from the brain. And towards the end, we will also talk about some non-invasive imaging markers of human brain clearance that has been proposed. And finally, if we have time for this ambitious presentation regarding time, we will talk about the CSF tracer efflux to the meninges and the skull, implying a CNS lymphatic crosstalk. So just as an introduction, we all know that the brain is immersed in water, in cerebrospinal fluid. This is important for protection of the brain and also for nutrition of the brain. Now, in 2012, it was also proposed from the Danish researcher Mike Nedergaard and her co-workers working in Rochester, New York, that the CSF or the cerebrospinal fluid also has a metabolic role for the brain. They had studied mice or rodents in the lab, and they found that CSF can be important to clear the brain of waste solutes. And I hope you now can see my arrow where I am pointing. But their concept was that CSF enters the brain along penetrating arteries. And we go here, CSF, and then CSF enters the brain interstitial space and moves through the interstitium by net fluid flow over to the perivenous side where these solutes or waste products are cleared from the brain. And these solutes might be amyloid beta, tau, alpha-synuclein, lactate, and so on. And this is then a perivascular clearance pathway which shares some features with lymph, and it's so-called pseudolymph, and therefore also the name glia lymphatic, because this system was dependent on glia cells and their end feet surrounding these perivascular spaces within the brain cortex. Within this concept, the healthy pulsating arteries was one main element, and this bridges very beautifully what we know, that healthy arteries provides also for a healthy brain. And when we think about it, many of these large pulsating arteries, they are within the subarachnoid space, and they drive the CSF flow towards the brain tissue. Okay, and if we close up, this is from an animal, 2-photon in vivo microscopy. We see one snapshot with particles introduced into CSF and how they are really propagated in the perivascular space of the arteries. These are pile arteries at the immediate brain surface before they enter the brain tissue. So pulsations, healthy arteries are important for this glymphatic system to work. It was also the year after the first description of the glymphatic system shown that this is really active during sleep in mice. And the concept is that the glial cells contract a little bit, and the interstitial space widens up, and that renders for a faster glymphatic flow through the interstitial space and a larger clearance of solutes like amyloid beta. So this really, sparked the attention, because now suddenly you had a link between sleep and also dementia, where amyloid beta and tau are accumulated in the brain. And this was very compelling finding. So it was like turning the light on and off. So in sleep, you saw a very much high transport of solutes in the perivascular space. And when the mice were awake, there was almost nothing. And this is, has been described in recent books and really given us some understanding of perhaps why we sleep. And this was also, popularized through some media outlets and more or less tabloid speaking. This was some sort of a brainwash. So the CSF is the brain's washing system for clearing amyloid beta and tau along the vessels from the brain to avoid dementia, and particularly Alzheimer's disease, to say it very, very easy. And in later research, there has been reports that other diseases than also Alzheimer's maybe have an implication in glymphatic system function, namely other also cardiovascular disorders like hypertension and stroke, but also in psychiatric disorders, circadian misalignment, obesity, sleep apnea, and substance abuse. And all this might lead to a vicious circle where you accumulate aggregates in the brain, causes neuroinflammation, which goes further to neurodegeneration and then dementia. Okay, so now in recent years, we should note that there are other concepts to understand how the brain clears itself from waste products outside blood vessels. And the glymphatic model is, as I proposed here in this cartoon, but already we had the intramural periarterial drainage model, the IPAD model. And it's been a lot of discussion between the groups. This is a quite controversial research field, and a lot of discussion between these groups about how solutes are cleared from the brain. Is it outside the blood vessel in the perivascular space along veins, or is it actually in the artery vessel wall? And this, resonates quite well with what you see in cerebral amyloid angiopathy, where amyloid is deposited within the artery wall. But if this is synonymous to this is the most important clearance route, that is another story. And finally, a little more, diplomatic, perhaps, model is the mixing model, where CSF is mixed in the periarterial space, but whereas there is no net transport of solids through the interstitium, but just diffusion of solutes from the interstitial space into the periarterial space and then out again into the subarachnoid space. In the first model of the glymphatic system, it was also theorized that potentially the perivenous drainage is continuous out to the lymphatic vessels within the dura. But I think that is not the prevailing theory, and that is not what we think either, and I will come back to that. Okay, then going over to intrathecal tracer enhanced MRI, or gMRI. That it was in 2012 that the first rodent report was published, and we published the first report in humans in 2015, where we proposed that there might be a glymphatic system also in the human brain. And we based this on exams with intrathecal MRI contrast. We used gadobutrol. And this was just very simple. We had some region of interest within the brain tissue, and we saw that the signal intensity increased over time. And as you see already here, that you have to do imaging for many hours later than the injection to really to grasp this phenomenon. And gadobutrol as a CSF tracer, this is an MRI contrast agent, which is widely used in the world. We think this is quite suitable as a tracer within the cerebrospinal fluid and to monitor extravascular pathways in the brain. It's hydrophilic, it's a small molecule, still larger than water and smaller than amyloid beta and tau. But its size can assume it to be able to enter the periarterial spaces and also the gaps between the astrocytic end feeds that are in electron microscopy reported to be wider, much wider than the hydraulic diameter of gadobutrol. It's also an inert molecule. It's not metabolized. It does not bind to protein. And importantly, it is mainly contained outside the blood-brain barrier. So here, when it enters the brain from surface, we are already outside the blood vessels, and we can assume there is little leakage back into the blood because of the intact blood-brain barrier. So this is an extravascular tracer of brain enhancement and brain clearance to and from the subarachnoid compartment. So this is the methodology. Very briefly, we started doing this on a routinely basis in studies in 2015, and we have continued since then, actually, up until today, and studies are still going on. And the study setup is quite easy. You do a pre-scan T1 weighted image, and then you inject the intrathecal gadobutrol, and then you do consecutive T1 weighted imaging up to 24, 48, or even 72 hours. And then we also had one follow-up after 4 weeks, just to see that all the contrast agent had been cleared from the system. And of course, you can do other sorts of imaging along with the T1 weighted scan, but this is more or less the principles of the gMRI routine. In our studies, we did patients who were under workup of CSF disorders in the neurosurgical department. So it was symptomatic patients. And one of the larger groups of this was patients with dementia subtype, idiopathic normal pressure hydrocephalus, which has enlarged ventricles and pathological CSF flow patterns. Okay, about safety, because this is off-label administration, intrathecal gadobutrol is off-label, so it's only approved in a clinical setting for intravenous use. So we did this under approval of the Regional Ethical Committee and the National Medicine Agency and the Hospital Authority. And also we have always had informed consent from the patients. So we use the lowest diagnostic dose that we can. We are pushing now for even lower doses, and this is like 30 to 50 times lower in total than an intravenous dose. We use a small syringe and we mix gadobutrol with saline to reduce any neurotoxicity. We inject slowly. We monitor the patients closely. And we have done several safety studies. A total of 345 patients have now been enrolled in safety studies. And our experience shows that the side effects, they are moderate and they are short-lived. So there were no remaining signs of side effects after 4 weeks in these studies. So we think it's a quite beneficial safety profile. And this also resonates well with the clinical experiences. This is from a radiology paper where they did a meta-analysis of more than 1,000 patients who had undergone intrathecal gadolinium enhanced MRI for clinical indications. And as it says here, that 1 millimole and less are considered to be safe, but you should not go over 1 millimole. 2 millimole and more have been associated with serious neurotoxic complications. And we have also commented further on this in radiology, and for those who are particularly interested in it, you can read more here. We also looked at gadolinium retention in the brain, because this has been an issue within neuroradiology, that the use of gadolinium-based contrast agents have been associated with retention in the brain, particularly in the basal ganglia. And we looked at this with T1 mapping after 4 weeks, and we found no sign of retention in the brain whatsoever. This is one field of interest, and it has been reported by the group of Katarina Deike and Alexander Albruch, which are located in Bonn, in your country, where they showed here by heavily weighted T2 imaging after IV dosage that gadolinium leaks into CSF at many weak barriers, as you see here. Depicted on this illustration. So CSF from intravenous, it leaks. And it has been proposed previously that perhaps this could be some sort of a less invasive way of assessing the perivascular pathways of the brain, because if it leaks into CSF, then it could then again enter the brain. However, we now know that intravenous contrast agents also leak directly into brain tissue over the blood-brain barrier. So the blood-brain barrier is a semi-permeable barrier. And after like 2.5 hours, this is modeled in a study we did together with Thijs van Os from Leiden in the Netherlands and Anders Wåhlin from Umeå in Sweden, where we model that the tissue concentration of gadolinium after an IV scan is at maximum after 2.5 hours, and then it is the same as in blood, and then it will decline as a gradient goes in the other direction. So we believe that the mechanism of gadolinium retention in the brain is probably from IV dosing and not via the CSF route. And particularly in the basal ganglia, there is very little or no intrathecal gadolinium to find at any time point. Okay, but first let's look some more about what's going on at the brain surface after an intrathecal administration. And first, actually, within the spine, we inject at the lumbar level, L3, L4 typically. And I think it's interesting to see the spinal transit time. How fast does it take from the injection and administration here at the lumbar region until we see first evidence of it at the craniocervical junction? And typically, it's quite short. The shortest I have seen was less than 5 minutes, but typically with a median 10 to 20 minutes. That's a typical. Some few patients have very, very long spinal transit times. It could be that they have a spinal stenosis, degeneration, and because we did not scan the spine of all patients, but we looked at the craniocervical junction as part of the head scan. But very, very short transit time, I must say. And of course, pulsations, diffusion, respiration, many forces probably contribute to this fast spinal transit time. And I think it's important to appreciate that the dose that we inject, up to 3/4 of it, seems to be absorbed already within the spinal canal. So the potential for CSF resorption and efflux is quite large within the spinal canal. So this is one example where you see the tracer or the contrast agent here being white at this T1 image at the base, but you have no tracer yet around the upper convexities. Still, at this time point, we see the peak in blood. So we have done multiple blood testing, and we have tracked the gadolinium within the blood, and as you see, the peak in blood is much earlier than at the upper convexities. And we think that the lymphatic vessels within the dura and also the drainage along the perineural sleeves is important for drainage from the spinal canal. At least it's a very fast and effective system for drainage of solids. This is how it looks at one time point. This is approximately after 2 hours after injection. And here you see what is not an angiogram, but it's more like a peri-angiogram of the intrathecal contrast agent within the cranial compartment. And you see the distribution along the upper spinal canal and the basal cistern is quite diffuse. But as soon as it enters the supratentorial compartment, you see that the tracer really accumulates along the arteries, the large artery trunks. And this is perpendicular. And you see this donut-like pattern. And it obviously seems to be ensheathed by a membrane here in the periphery. Here you have the artery. So this is the first time this is imaged in vivo in a human. And we have just called it the perivascular subarachnoid space because we are in the subarachnoid space, but it seems to be a compartmentalized subarachnoid space. So you have an inner and you have an outer subarachnoid compartment. And we found that these compartments seem to be important for the speed of which the tracer propagates within a subarachnoid compartment, because in patients with normal pressure hydrocephalus, these are really dilated, and the transport time to the periphery is clearly delayed in these patients. And we know that this is a patient group with a lot of vascular comorbidity and also reduced intracranial compliance regarding pressure. So we don't really know the mechanism. We don't know the dilatation of these perivascular subarachnoid spaces. Is it the cause or an effect? But at least it's a description. And this is, of course, something that should be studied more thoroughly in further studies. And there are now one group that we cooperate with in Leiden with Thijs van Osch, where they look at these spaces doing so-called CSF stream, which is non-invasive tracking of water motions in these perivascular spaces. And their maps are really in good agreement with what we see after intrathecal contrast agents. So that's a very exciting research cooperation we have there. So now we have looked at the surface. So now let's go into the brain and see what happens there when the intrathecal gadobutrol reaches the brain surface. As I said, this was a controversial field, and there were groups that argued for that there is no glymphatic system at all, and there is no perivascular space actually within the human brain. And this was based on human brain specimens, which was in vitro and not in vivo. So we did not know really what to expect when we looked at the human brain in vivo. And you know, this is the power of radiology, when you have really in vivo observations, and you can follow this over an extended time period. And here is what you see is CSF tracer enhancement within the brain tissue. We have here subtracted the contrast agent from the subarachnoid compartment. So there is nothing here on the surface. This is all within the brain tissue. And you see that this is an enhancement pattern that has a sort of a pattern where it enhances first and the most in brain tissue, which is adjacent to the large arteries at the brain surface. So here you see typically enhancement along the anterior cerebral arteries, here adjacent to the middle cerebral arteries, and here adjacent to the posterior cerebral arteries. So this tells us something, that pulsations may be important for CSF influx to the brain. And after 24 hours, you see this typically can be quite brain-wide, and it's much more diffuse. So this pattern with first and most enhancement along arteries are mostly what we see at the earliest time points, and the later time points is more or less diffuse. You see the enhancement is centripetal, not diffuse, and it's mainly a cortical phenomenon. Not so much going on, and this is also well in line with animal studies which shows that CSF exchange with the brain is mainly a cortex phenomenon. Some of our, experience and what has been quite compelling, and I wanted to show you this, is the heterogeneity. Patients and people are not the same when it comes to tracer enhancement. And these are 8 different subjects from one of the studies we have published. And I think it's really striking how different this is. And you may wonder, if there is no CSF net influx to larger parts of these areas, how important is then CSF tracer influx, or the glymphatic system, for that sake, in these regions where we see no net influx to the brain? We have looked at this in different conditions. This was patients who had underwent subarachnoid hemorrhage, which is a bleeding at the brain surface. And here you see some blood deposits on this susceptibility weighted image on the brain surface. And here you see the corresponding gMRI map, color map, where there is no CSF influx to that part of the brain, comparing with a more normal pattern on the contralateral side. Still, these patients do not have hemiatrophy or hemi-Alzheimer, so you might wonder, how important is this after all for neurodegeneration? We don't really know that, but I think it's strange that this remarkable asymmetry does not lead to brain atrophy, because we do not see hemiatrophy either in the long term of patients who have underwent subarachnoid hemorrhage. And this was patients who with spinal CSF leakages with spontaneous intracranial hypertension. And typically the CSF tracer bolus does not go very high above the equator. And here you see also a very, very large difference between the reference subjects and the patients with respects to enhancement in the brain. So this can, of course, be patients with some cognitive disabilities. So I mean, we cannot rule out that this is important for some parts of cognition, but well, this is not patients that turn out to get Alzheimer's in the long run either. You know, when we dose intrathecal, we also see that there is a tremendous potential for, you know, drugging the brain. And this was one patient with grade 3 glioma in the brain. After intravenous contrast, there was no enhancement, meaning that if you had given a drug intravenously, you could have expected quite little movement of the therapeutic drug from the blood circulation into the tumor tissue. However, when you bypass the blood-brain barrier and you go intrathecally, you are already outside the blood-brain barrier, as I said. And here you see enhancement after 24 hours, which is higher within the tumor than in the rest of the brain. And actually, it also persists and remains in the brain for longer than the brain that appears to be normal. So we think there is a larger potential for drugging brain disease via the intrathecal route than has previously been appreciated, actually. And just to mention that there are already drugs that we administer in the CSF intrathecally that I don't think we have fully appreciated, that these drugs can be expected also to enter the brain and not just work at the brain surface and towards the meninges. Now let's have a look at the tracer clearance from the brain, because this is actually, you know, the ultimate question. This is what it started with. Is tracer clearance impaired? Is solute clearance from the brain impaired? And here, of course, the hypothesis is that gadobutrol as a tracer can be a surrogate marker for other larger solutes that we truly would like to see cleared from the brain, but we have no means to do it. But here we assume or hypothesize that gadobutrol clearance from the brain can be a surrogate marker for clearance of larger molecules like amyloid beta and tau. Concerning clearance, we have done one interventional study, and that intervention was sleep deprivation. So we had a group of a few patients who turned out to be reference subjects, meaning that we could not find any treatable CSF disorder, and we compared them with other reference subjects who were allowed to sleep as much as they wanted. And here you see that the enhancement in the cerebral cortex are not different until the first afternoon we inject in the morning, and this is the afternoon at day 1. But then the groups are different. So in the sleep deprivation group, which is the red one here, you see a higher amount of tracer in the brain after 24 hours, which is the next morning, than in the group that was sleeping. So impaired sleep seems to have a reduced clearance from the brain. And of course, this resonates very well with the rodent studies. But I must say that this difference is quite modest, actually, considering the quite heavy intervention of total sleep deprivation for 24 hours. And I'm not so sure that impaired sleep in the very long run is a very, very heavy factor in the dementia evolvement or pathogenesis. It could also be the other way around, that Alzheimer's disease leads to impaired sleep. And there are some population studies that underscores that, but I don't have the time to go into them right now. And when we look at which parts from the brain clearance is impaired when we went to the dementia subtype, idiopathic non-pressure hydrocephalus, we can compare this with how tau protein is deposited in brain during the increasing Braak stages. And what you see here is tau deposits in the cortex. This is, Alzheimer's is mainly a cortical disease. And it appears first here in the entorhinal cortex region and the hippocampus, and then it spreads to other and larger parts of the brain. And here you see that those similar parts that are involved in deposition in Alzheimer's are also those areas of the brain with the highest CSF exchange, and also with the largest degree of impaired clearance. Here, the hippocampus, the entorhinal cortex, the insula, and the singular cortex. We think this is quite interesting, but it's just an association. So it's not the final proof, but it's interesting observation. And it has been from the patterns that we have shown suggested by Mark Nedergaard and co-workers that this might be one underlying explanation for how some dementia diseases spread in the brain. It could be like they follow this glymphatic pattern of CSF exchange. But that's also of course just talking about associations, and we have no proof of cause and effect, at least not from our end. What we know is that the tracer levels in CSF and the brain are highly associated, meaning that if CSF clearance is reduced, clearance from the brain is reduced. So to clear the brain fast, you would also want to clear the CSF and the subarachnoid compartment fast. So we think that the efflux from the brain goes via the subarachnoid space and then further out, not directly to lymph or something. So what is the crucial factor, as we see it, is CSF clearance from the brain surface. And based on this, we thought perhaps we could just measure this CSF clearance rate, and perhaps we could even skip the imaging, which is very expensive. So along with the imaging, we also obtained blood samples from these patients consecutively at quite many time points for each patient. And then we looked at the levels of gadolinium in blood after the intrathecal injection. And that was quite interesting to see, because here on the left, you see differences between different patients group. This is pineal cyst, arachnoid cyst, spontaneous intracranial hypertension, idiopathic intracranial hypertension, normal pressure hydrocephalus, and communicating and non-communicating hydrocephalus. And these are the references who turn out to have no diagnosis after an extensive workup. And there are group differences. We didn't know that, but now we see that they have different clearance rates by group-wise. But also, and I think this is perhaps at least as interesting, if you looked within each group, patients or people or subjects seem to have different CSF clearance profiles. So this seems to be a unique feature of the system of each and one of us, that we have our own CSF clearance signature. We clear CSF at different rates. And this could be important information in a neurodegeneration setting, if this is some sort of a dynamic biomarker of how also endogenous solutes like amyloid beta and tau are cleared. That could be important. But of course also for intrathecal treatments. So if you would in the future drug the brain via the intrathecal route, of course you would also like to know the brain's creatinine, and not only the blood creatinine, So you would like to have a clearance profile of actually each subject before you dose a potentially toxic intrathecal drug. So we think this could be one way of tailoring intrathecal doses of drugs when you want to treat disease, not only at the meninges, but also within the brain. Now, there have been some proposals that human brain clearance can be imaged non-invasively. And without intrathecal or intravenous contrast agent. I would just like to comment on a couple of these. One proposed method is to assess enlarged perivascular spaces in the brain. As you who are working with MRI knows, these are detected at high field MRI more if you have 7 Tesla, less if you have 1.5 Tesla, but they are typically all in the cerebral white matter and in the basal ganglia. And doing volumetry or counts of enlarged perivascular spaces in white matter have been proposed as one indicator or surrogate marker of perivascular clearance dysfunction. Now, again, I would like to emphasize that CSF exchange with the brain, or what we say glymphatic exchange, is a cortical phenomenon by large. This is from the animal brain, ex vivo. This is human brain from one of our studies in vivo. And this is specimens showing deposits in Alzheimer's disease. And you see this is a cortical disease, no deposits within the white matter of the brain. So the thinking here is, I guess, and from this publication at least, that if you have a clearance obstruction around arteries here in the cortex, even if you don't see the enlarged perivascular space because you don't do that in the cortex, this is, an upstream dilatation within the white matter as an indicator of clearance dysfunction in the cortex. So that seems to be the rationale. But these enlarged perivascular spaces, they are around these medullary arteries. Medullary arteries, they have not so much to do with the cortex. The cortex has its own intracortical arteries, and this is from the cortex. We can go into larger detail here, but the cortex is very, very vascularized, and the white matter is not so vascularized. And those few cortical arteries that cross the gray-white matter junction, they bend over to run in parallel with the cortex and not perpendicular to it as the medullary arteries do. So when the thinking is that enlarged perivascular spaces is an upstream dilatation due to clearance dysfunction in the cortex, I don't think we actually have the anatomical substrate to claim that, because this is around medullary arteries, which are specialized arteries to supply the white matter and not the gray. Then you also have other proposed methods like the DTI-ALPS, which has attracted a lot of enthusiasm in the imaging community. And this is also a measuring of directional mobility of water in the deep cerebral white matter. Again, this is assessing an assessment of water mobility within a deep white matter, not the cortex. And also, of course, the voxels here are much, much larger than the very small perivascular space. And I think it's very, very likely that this method assesses other features of the white matter than directional water mobility. It could at least be intraaxonal water mobility. And I think the imaging community that have looked thoroughly on this, I'm part of a European consortium, and we are now writing a review, a meta-analysis of the methodology. And we really do not believe that this is the way, that you cannot use directional water mobility in one part of deep white matter to say something about the clearance of amyloid beta and tau from the entire brain cortex. We think it could be useful to assess the white matter, but not to use it as a marker of perivascular human brain clearance. So I think this is one example that you try to do some translational research, which means to translate animal findings about perivascular flow to the human setting. And when the imaging community heard about perivascular spaces, we thought that yes, we see perivascular spaces, but I think this is actually at the wrong place. Those parts of the brain that we really should be interested in is the cortex and not the deep white matter. So I think this perhaps may have been lost in translation actually. Now the time is running, I see, and I promised Majar here that I would speed up in the end, and I will. So if I can use at least 2 minutes just to say something about the CSF tracer efflux to the meninges, because now we are at the outside of the brain, and we are talking about how does CSF communicate with its outer boundaries. And the importance and the relevance here is that in 2015, 2 groups actually discovered that that within the meninges you have true lymphatic vessels draining CSF. This was a major breakthrough. There are lymphatic vessels within the dura that drains CSF. And it has been shown that with degeneration of these dural lymphatic vessels, you will also have a deteriorated clearance from the CSF and the brain. So here you already have the link to potentially neurodegeneration. But also, this renders or makes the ground for a crosstalk between peripheral immune system elements and the brain with CSF as a mediator. So if the brain can excrete products into the CSF, and it can also go into the parasagittal dural space, you have enabling communication and crosstalk both ways between peripheral lymphatic vessels and the brain. So we looked at this with our methodology, and this is the parasagittal dural region, which is, a tissue. Looks like this. This is a superior sagittal sinus. And we just looked at the tracer enhancement, CSF tracer enhancement over time. And already after 3 hours, we see the signal increase within this tissue. So now we confirmed intrathecal tracer enhancement within the meninges, within the parasagittal dural space. And there we, for the first time, show that there may be also in humans a potential interaction or crosstalk between peripheral immune elements, which we know from basic studies are here in the parasagittal dura, and the brain. And you see that it's associated with the level of tracer in the CSF or the subarachnoid compartment, but not the same. And interestingly, it has been shown also by micro-CT that there are some small channels within the calvarium, the skull. So actually, we also looked for tracer enhancement within the bone marrow. And we found it. It was a small effect, but still significant. So it seems that also the brain and the CSF can not only communicate with the parasagittal dura and peripheral lymphatic vessels, but also central immune elements within the bone marrow. And this has quite large pathogenic implications for, immunological disease, but also for cancer disease and degenerative disease that I have not the time to even mention here during this talk, but I will just, mention it. And so this is the parasagittal dural space. And this has also evolved now to be, one research field. You can, for instance, do volumetry and look at how the volumes of the PSD is different between patients, groups, and so on. It was recently out a paper from a group in Tennessee where they showed that the volume of the PSD was larger in patients with multiple sclerosis and so on. Also here, it has been proposed some methods for non-invasively image lymph in the PSD, but this is, of course, very much else than lymph. This is capillaries, this is veins, this is stroma. So I would not recommend that you just image the PSD at FLAIR and just say that this is lymph. Neither flow artifacts that obviously are here at the base of the skull. This was also interpreted as lymph, and we have written about this as a commentary for those of you who are interested. So I will now go in for my landing. Just to conclude that CSF exchange occurs with the brain, meninges, and bone marrow. And this may be clinically relevant to a range of common neurological diseases. Intrathecal contrast-enhanced MRI can assess brain clearance function and brain immune crosstalk. CSF clearance capacity is individual and can be measured by CSF2 blood clearance testing. If you know the CSF clearance, or in other words, the brain's creatinine, may be important to tailor dosages of intrathecal drugs and assess dementia risk. And non-invasive methods are limited by validity issues, and we should be very careful about how we interpret our findings. So, thank you for your attention.
Thank you for this wonderful presentation. Now we will open the session for questions. If you have questions, feel free to turn on your microphone and speak up, or you could just post it in the chat. And I believe we already have a question in the chat. Given that gadobutrol does not penetrate BBB, how does it end up in blood flow following an intrathecal injection? Conversely, how does IV gadobutrol end up in CSF? Do the kinetics of these leakages give a clue to the mechanism? Example, lymphatic drainage from CSF followed by exchange into blood.
Yes, very big question. And we have written a review paper on that, actually, for the one who asked the question. It's in NMR Biomedicine from last year with Thijs van Os as first author and me as senior author. In short, we think that from CSF to blood, the clearance from the spinal canal is important, probably through lymphatic vessels encircling the perineural nerve sheets, and also dural vessels within the dura itself. We have seen that CSF effluxes through the base of the skull along the cranial nerves. And we have also found CSF tracer enhancement in lymph nodes in the neck. That's another research topic that I did not have the time to go into, but it's very exciting. And as I said, it does not cross the blood-brain barrier backwards much. But in our models where we have looked at this together with our collaborating mathematicians from the University of Oslo, they seem also to find that there is some leakage from the brain tissue, and we think that could be some intrathecal gadolinium leaking into blood vessels also from the brain. But the major proportion of the efflux from the system is from the spinal canal and the base of the skull, and then via other routes. Of course, we know that also the arteries at the brain surface, where we have very, very tremendous exchanges of water, you do not have these tight junctions as you have within the brain. So also the vessels at the brain surface are leakier, and it could also be hypothesized to directly also resorb the intrathecal gadobutrol, actually. I hope that was at least part of the answer. I see we are running out of time here, so if there was another one, perhaps we should go for the next.
It's fine, yeah. There is one more question. Thank you for this interesting talk. Have you thought of methods to manipulate the uptake and release of tracer in tissue based on parameters that can be manipulated in subject? I'm thinking of something analog to breath hold or CO2 breathing in quantitative fMRI. Could there be a way to manipulate the state of the subjects, for example, blood pressure, to create different rates of tracer uptake and release, which could then be fitted with a model or provide a way of reducing the variability you saw between people?
Great question. And of course, this goes into what can you do with all this information? Can you do some intervention to improve clearance? And, about breath hold and breathing, it's very hard because, we are here talking about events going on at very long term. We are looking at things going on through hours and even days. And our, time resolution through this imaging routine is very, very poor. So it would be very, very hard to image the effect of the respiration. Then I think you would have to have methods that were much more, one shot, like phase contrast MRI or anything like that. So it has been, in animals, been considered. Could you do some like hyperosmotic intravenous treatment and so on? This is very hard, to do in patients, and it's very, very hard, to, or we wouldn't even try to get approvals of doing too many more manipulations of the system in living patients. So I think that's more or less mostly a question for the animal researchers. However, we are about to go into some research projects with a hospital in the US where they will do bypass surgery in the cervical area, a lymphovenous bypass to try to accelerate the lymphatic drainage to bypass fibrotic lymph nodes, which we know comes with age, to try to accelerate CSF clearance from the system with the knowledge that CSF clearance is so important. And then they will use intrathecal MRI to assess the effect of their interventional surgery. So that's, exciting. That's somebody who really wants to do a difference and do something that might improve perivascular clearance from the brain in these patients.
We've got one more question. In the glioblastoma study, why did the tumor not enhance with IV contrast, but did enhance with intrathecal contrast?
Yeah, good question. Yeah, it was an anaplastic astrocytoma grade 3. And most of them actually do not enhance with intravenous contrast. So that was not so surprising. And that means that in this tumor, the blood-brain barrier is still intact. So it's not so aggressive that it breaks down the blood-brain barrier. It grows diffusely along the vessels and within the interstitial space, but it does not break the blood-brain barrier. But when you administer intrathecally, the tracer enters the brain from surface outside the blood vessels. And then you have access to the interstitial space without crossing the blood-brain barrier. And that's the big difference between those two approaches.
Thank you. Are there any more questions from the audience? I'll give you a minute. Well, if that's not the case, then thank you again, Professor Ringstad, for this wonderful talk.
Thank you. It was my pleasure.
It was our pleasure to have you here on the KIS seminar. And to the audience, thank you so much for tuning in. I wish you all a pleasant evening, night, morning, wherever you may be. Until next time.
Thank you.